Usually when we look at a map, we expect to see continents, oceans, maybe topographical lines.
Right, geographical borders, things like that.
Exactly. We rely on those geographical maps to tell us exactly where things are. But what if I told you that one of the most accurate, high-resolution maps of a person's entire life course is, well, sitting right there under their nose?
And you mean that quite literally.
Literally, think about it. A map that records their geographic origins, their economic status, their environmental exposures, and their biological history.
All meticulously archived right there in calcified tissue and mucous membranes.
It's wild. We are, of course, talking about the human mouth. And whether you are a public health trainee, a junior doctor prepping for your boards, or just deeply curious about how health systems actually function behind the scenes, today's deep dive is your structured conceptual companion guide. Our mission today is to do a massive, thorough exploration of the frameworks laid out in the Oxford textbook of global public health. We want to strengthen your clinical reasoning and carefully map the exact path from a biological risk to an environmental exposure and ultimately to a systemic impact.
And we're focusing specifically on Chapter 8.8, which is dental public health.
Right.
To a lot of people working within the broader medical field, dentistry can sometimes feel siloed.
Oh, definitely. Like it's happening in a completely separate building.
Yeah, physically and philosophically. But what makes dental public health so crucial for anyone studying population health is that it perfectly illustrates the fundamental tension in modern medicine.
The battle between downstream clinical treatment and upstream engineering.
Exactly. The traditional drilling and filling versus, actual public health engineering.
So let's jump right into that tension, because to really understand why we might need massive upstream structural engineering, we first have to take a hard look at the staggering scale of the structural damage occurring worldwide.
The global burden of oral disease.
Right. And the numbers we're dealing with are, frankly, hard to wrap your head around. It almost feels like a hidden pandemic.
The scale is immense. And the reason these diseases are so easily overlooked in broader health policy discussions really comes down to the nature of the diseases themselves.
Because it's not like an infectious outbreak, right?
Exactly. The immense societal burden here largely reflects the cumulative impact of a massive number of people who are affected to a modest degree.
Right.
Alongside a significant minority who are affected very severely. It doesn't present with the immediate dramatic mortality of an infectious disease, so it just slips under the radar of health system planners.
Which brings us to this really fascinating concept from the text, the paradox of plenty.
Oh yeah, this is a great anchor.
Consider this striking statistic. England is widely recognized as having some of the best child dental health in the developed world.
They have excellent resources, the National Health Service, widespread fluoride toothpaste.
Yeah, all of that. Plenty. And yet, despite all of that, 38% of 5-year-olds there have clinically significant tooth decay.
It's staggering.
Almost 4 out of 10 kids by the time they are 5 years old. And globally, if you look at 12-year-olds, the average is 1.67 decayed, missing, or filled teeth per child.
And it doesn't stop with childhood. As you move through the life course, the prevalence remains remarkably high. More than 80% of adults globally have gingivitis.
Which is the superficial inflammation of the gums.
Right. And most adults show evidence of periodontitis, which is the actual structural destruction of the attachment between the tooth and the bone.
And then at the most severe end of the spectrum, you have oral cancer.
Yeah, it's the 8th most common cancer worldwide. In places like India and Sri Lanka, it's incredibly prevalent, sometimes making up to 40% of all cancers there due to specific cultural practices.
Wow, up to 40%. I want to look at the economic weight of all this because it is just crushing.
It really is.
The direct costs of oral disease account for 0.2% to 1% of the gross national product in developed nations. To put a hard number on that, the UK's NHS budget's approximately £2.5 billion for dentistry.
But here is the kicker with that number. That $2.5 billion only covers about 50% of the population who are actually registered with an NHS dentist.
Meaning the true cost, once you factor in private care and out-of-pocket expenses, is way, way higher.
Significantly higher. But if we connect this to the bigger picture, we can't just look at the direct financial costs of running clinics or buying materials.
Right, the indirect costs.
Yes, the indirect costs act as a massive silent drain on society. In the United States alone, oral disease and its treatment lead to over 20 million lost workdays and 51 million lost school hours every single year.
Wait, 51 million school hours, let's just visualize that for a second. That is an astronomical amount of missed education.
It really is.
That's children sitting in classrooms unable to focus because of a throbbing toothache or missing theirs entirely to travel to a clinic to get a tooth pulled. Think about what that means for a child's long-term educational trajectory.
Especially for a child who might already be struggling academically. It creates a compounding disadvantage.
Yeah.
And this requires us to break down how we actually frame the concept of disease impact. In public health, we don't just measure the burden of disease in terms of mortality.
The oral cancer mortality is high.
True, the 5-year survival rate for oral cancer remains less than 50%, which is devastating. But for the vast majority of oral disease, we have to measure systemic morbidity.
Okay, break that down for us. What does that systemic morbidity look like in early childhood?
Well, we're talking about early childhood caries causing such severe pain and chronic systemic infection that it literally limits a child's physical growth and development.
Wow.
At the most critical stage of their life, their sleep is disrupted, their nutrition is compromised, their endocrine system is stressed.
And what does that systemic morbidity look like at the other end of the life course for older adults?
For older adults, we are looking at conditions like xerostomia.
Dry mouth.
Right. Severe dry mouth, often caused by polypharmacy or poorly fitting dentures. These issues severely limit dietary choices. An older adult who cannot chew fibrous vegetables or proteins will shift their diet to soft, highly processed, carbohydrate-rich foods.
Which just accelerates malnutrition and frailty.
Exactly. Plus, we must acknowledge the profound impact on quality of life and social mobility. Visible dental disease heavily influences how people are judged in job interviews. It becomes this visible marker of disadvantage.
Okay, let me push back here, or rather point out a massive contradiction that seems to be glaring at us from the text.
Go for it.
The overarching consensus in the literature is that dental caries and periodontal disease are, quote, almost entirely preventable.
Yes.
If they are almost entirely preventable, why is the Western biomedical model of treating these diseases so incredibly expensive?
Right.
I mean, it's so expensive that adopting this model would literally bankrupt a developing nation's entire healthcare budget. How did we build a system that spends billions to treat something that shouldn't be happening in the first place?
That is the pivotal question of health systems design. The answer lies in the fundamental difference between a prevention-oriented model and a treatment-oriented model.
And we are very much treatment-oriented.
Overwhelmingly so.
Yeah.
The Western biomedical model waits for the disease process to fully manifest as structural tissue damage. And then it deploys highly trained, highly paid surgical specialists, dentists, working in incredibly expensive, technology-intensive microenvironments to surgically repair the damage on a tooth-by-tooth basis.
So it's a downstream surgical intervention trying to solve an upstream environmental problem.
Exactly. When you have a disease that affects 80 to 90% of the population to some degree, a downstream surgical response is inherently unsustainable. You cannot drill and fill your way out of a public health crisis.
It's just math at that point.
Yeah, the cumulative impact of that widespread modest disease creates a massive societal burden that individualized downstream surgery simply cannot keep up with. If a developing nation with a rising incidence of tooth decay attempts to solve the problem by training thousands of traditional dentists, they will exhaust their healthcare resources instantly.
And the disease prevalence will still just continue to rise.
Exactly.
So if we want to figure out how to actually prevent these diseases upstream, we have to first look incredibly closely at the exact biological and environmental mechanisms that cause them. We need to look at what the text calls the oral diseases of public health importance.
Let's call them the Big Four.
The big four: dental caries, periodontal diseases, oral cancer, and trauma.
Understanding the deep pathogenesis and the epidemiology of these four is essential for clinical pattern recognition.
So I'll start with the heavy hitter, dental caries. This accounts for 93 to 98% of the global burden of oral disease.
It's massive.
Now, I always assumed a cavity was just a hole that formed because you didn't brush. But the framework is much more complex. There are 4 necessary factors that must all be present simultaneously for a cavity to develop.
Right.
You need dietary sugars, you need a susceptible tooth surface, you need the microflora of dental plaque, specifically bacteria like Streptococcus mutans, and you need time.
Let's look closely at that biological mechanism because it's not simply a matter of bacteria eating the tooth.
Right, it's not like tiny termites.
No, it is a complex ecological shift within a biofilm. The Streptococcus mutans and other cariogenic bacteria live within the dental plaque, which is that sticky biofilm matrix attached to the tooth. When you consume dietary sugars, specifically fermentable carbohydrates like sucrose, these bacteria metabolize the sugar for their own energy.
And as a byproduct of that, they excrete lactic acid.
Yes, and that acid causes a sharp drop in the pH of the fluid surrounding the tooth surface. The resting pH of the mouth is around 7.0, which is neutral, but when sugar is introduced, the plaque pH plummets.
And once it drops below what we call the critical pH,
Which is usually around 5.5.
right, below 5.5, the acid begins to dissolve the hydroxyapatite crystals that make up the tooth enamel. This process is called demineralization. Calcium and phosphate ions literally leach out of the tooth structure.
But the body has a defense mechanism, the saliva. Saliva is the hero of the oral cavity. It's supersaturated with calcium and phosphate, and it contains bicarbonate buffers.
So it fights back.
Exactly. Once the sugar is cleared from the mouth, the saliva works to neutralize the acid and pull those calcium and phosphate ions back into the enamel lattice. This is remineralization.
So it's this constant microscopic tug of war happening on the surface of your teeth all day long.
But if the frequency of sugar intake is too high, like if you were sipping a sugary soda constantly throughout the afternoon, the plaque pH remains below 5.5.
The remineralization process simply cannot keep up.
The enamel crystal matrix ultimately collapses and you get cavitation, a physical hole.
And how we actually measure that cavitation across a population has undergone a massive evolution. We don't just count the holes anymore.
This represents a profound epidemiological shift. For about 75 years, the gold standard for measuring population decay was the DMFT index.
Decayed, missing, and filled teeth.
Right.
I've heard an analogy for the DMFT index that makes its flaws painfully clear. Relying on the DMFT index today to understand true disease prevalence is a lot like trying to measure current crime rates in a city by looking exclusively at how many people are currently sitting in the local prison.
That is a brilliant way to conceptualize it.
Because a filled tooth or a missing tooth measures the healthcare system's past response to the disease just as much as it measures the actual disease itself.
The DMFT aggregates active disease and past treatment experience into a single number. It treats a tooth that was extracted 10 years ago, a tooth that has a silver filling, and a tooth that is currently actively decaying as exactly the same score.
It blurs the lines between biological reality and health system intervention.
Furthermore, in the old paradigm, a tooth was only counted as decayed if the clinician could stick a sharp metal explorer into it and feel it physically stick in a cavity. It required actual, irreversible tissue destruction to even register on the surveillance map.
Wow.
Today, public health surveillance has transitioned to the ICDAS, the International Caries Detection and Assessment System.
So how does ICDAS change the game?
ICDAS detects the disease process way before it turns into a physical hole. It visually detects pre-cavitation. Clinicians dry the tooth and look for very early chalky white spots on the enamel.
And those white spots mean the demineralization has started underneath.
Exactly. Subsurface demineralization has begun, but the outer enamel surface is actually still intact. This is a massive paradigm shift because it aligns our diagnostic criteria with our ultimate goal, prevention.
Because if you catch it at the white spot stage, it is entirely reversible.
Yes. You can arrest and remineralize that lesion with targeted fluoride applications and dietary changes. You do not need to pick up a surgical drill.
Speaking of drills and fillings, there is a fascinating demographic reality we have to discuss from the text. It's a cohort phenomenon known as the heavy metal generation.
This is a vital concept for anyone involved in health systems planning or geriatric care. The heavy metal generation refers to the cohort of people, generally over the age of 50 in developed nations, who grew up prior to the widespread introduction of fluoride toothpaste in the 1970s.
Because they didn't have fluoride, they suffered nearly universal severe dental caries as children.
They did, and they were treated with the standard biomedical model of their era, which was large mechanical amalgam fillings, the heavy metal.
But we have to remember a grim rule of clinical dentistry. No artificial restoration lasts forever.
Fillings fail. The margins degrade, microleakage occurs, secondary decay forms around the edges, and the tooth has to be drilled again. The next filling has to be larger.
And eventually there isn't enough tooth left to hold a filling, so it requires a crown. Then the nerve might die, requiring a root canal.
This is the restorative cycle of death for a tooth.
And now, this specific cohort is aging.
Yes. Unlike previous generations who simply had all their teeth extracted and transitioned to full dentures by age 60, the heavy metal generation is keeping their natural teeth much longer.
But those teeth are heavily compromised by decades of repeated surgical intervention.
They have complex, technology-intensive, lifelong maintenance needs. When those large amalgam restorations begin to fail en masse in a geriatric population that might now be dealing with cognitive decline or reduced manual dexterity, it places a massive burden on healthcare systems.
That is a demographic time bomb. Okay, so that is caries. Let's move to number 2 of the big four. Periodontal diseases. I think there is a lot of confusion about this, even among medical professionals. We need to clearly differentiate gingivitis versus periodontitis.
Blurring the two leads to poor clinical reasoning. Let's look at the anatomy. The gum tissue surrounds the tooth like a tight cuff. Gingivitis is inflammation restricted entirely to the superficial soft tissues.
So the gums get red, swollen, and they bleed easily when brushed.
But crucially, the underlying architectural support, the periodontal ligament fibers and the alveolar bone socket, remains completely intact. There is no loss of attachment.
And gingivitis is 100% reversible with good hygiene.
Exactly. So what triggers the shift to periodontitis? Periodontitis is a fundamentally different destructive process. It is characterized by the actual physical migration of the epithelial attachment down the root of the tooth, away from the crown.
And as it migrates, it leaves behind a deepened pocket.
Yes. This pocket becomes an anaerobic incubator for highly pathogenic gram-negative bacteria. The host's immune system detects these pathogens and mounts a massive inflammatory response,
Flooding the area with macrophages and neutrophils.
and releasing cytokines intended to destroy the bacteria. But in doing so, this hyperinflammatory response actually destroys the host's own periodontal ligament and alveolar bone. The structural support melts away.
Eventually, the teeth become loose and fall out. And unlike gingivitis, this bone loss is largely irreversible.
The prevalence of that severe destruction is surprisingly high. About 9% of adults in the UK and up to 25% in the US.
I always assumed, and I think a lot of people assume, that your gums just naturally recede and your teeth get loose as you get older, long in the tooth.
That is a very common misconception. Periodontitis is not a natural, inevitable consequence of biological aging. It is a specific pathological interaction between the dysbiotic pathogens in the plaque and the individual host's immune system.
And that immune response is modified by systemic risk factors.
Heavily modified. Smoking, for example, is devastating. It exerts an independent, aggressive, deleterious effect on the periodontium. It impairs immune function and causes peripheral vasoconstriction in the gums, which actually masks the bleeding.
Oh, wow. So a smoker might have severe disease, but their gums don't even look inflamed.
Exactly. Occupational stress and poorly controlled diabetes are other major systemic risk factors that dramatically accelerate periodontal destruction.
Let's examine number 3, oral cancer. These are mostly squamous cell carcinomas. What are the distinct risk factors we need to track here?
The risk factors are highly distinct and geographically variable. For cancer of the lip, the primary environmental hazard is long-term sunlight exposure, particularly ultraviolet radiation in fair-skinned individuals working outdoors.
And for intraoral cancer, the tongue, the floor of the mouth.
The primary drivers globally are heavy tobacco use and high alcohol consumption. In Southern Asia, the high incidence is heavily linked to the cultural practice of chewing betel quid or pan,
which is often mixed with tobacco and acts as a powerful localized carcinogen.
However, in Western nations, public health surveillance has detected a really important epidemiological shift over the last 2 decades. We are seeing a rising incidence in much younger cohorts, people under 45.
People who have never smoked.
Exactly. This rising incidence is linked to the human papillomavirus, specifically HPV-16. These HPV-associated tumors behave quite differently. They have a distinct anatomical predilection for the base of the tongue, the tonsils, and the oropharynx.
Though the text notes they often respond better to treatment than traditional tobacco-driven cancers.
They do. They carry a better overall prognosis.
Rounding out the big four, we have trauma. Dentofacial trauma has a 10 to 15% global prevalence. Now, normally we think of a broken tooth as just a random accident. A kid falls off a bike, bad luck. But public health doesn't view it that way.
No, public health views trauma as a predictable environmental exposure. The epidemiology shows clear patterns. Trauma incidence peaks in early adolescence, and it occurs more frequently in boys than girls.
And when we look upstream, the risk factors are structural.
Environmental hazards. playing contact sports without mandatory mouthguard policies, urban road traffic design that lacks safe cycling infrastructure, interpersonal violence, and overcrowded living conditions.
Even biological factors play a role, right? Like if a child has severely protruding upper front teeth, they have a dramatically increased risk of fracturing those teeth if they suffer a minor fall.
Exactly. The anatomy itself becomes a vulnerability to the environment.
Looking at these four disease categories, I want to circle back to something really profound regarding the epidemiology of dental caries in developed nations today. How does systems thinking apply to the way decay is distributed right now?
What's fascinating here is the concept of a bimodal distribution. If you go back to the mid-20th century, high caries prevalence was essentially universal. Almost everyone had a high disease burden.
But as overall disease levels have dropped over the past 50 years, the curve has changed.
It has become highly skewed. Today, the vast majority of the population, maybe 75%, enjoys very little or no obvious caries experience.
Yeah.
But there is a minority, roughly 20 to 25%, that shoulders almost the entire burden of moderate to severe disease.
And let me guess, that 20 to 25% isn't just randomly distributed.
Not at all. That severely affected minority is consistently and predictably concentrated in the most socioeconomically deprived areas.
So the aggregate average health of the nation looks much better on paper, but the inequality gap between the wealthiest and the poorest has actually widened significantly.
Widened dramatically.
If the 20 to 25% suffering the most severe biological damage in their mouths are concentrated entirely in deprived areas, it completely shatters the narrative that dental disease is just a failure of personal responsibility.
It isn't just about whether or not you remember to floss.
Exactly. It means the biological mechanisms occurring at the microscopic level in the mouth are directly mirroring the macroeconomic systemic inequalities of society.
This is where we shift our clinical gaze. We stop looking exclusively at the tooth, and we start looking at the whole patient, and more importantly, the society the patient is forced to navigate.
The literature outlines some incredibly complex associations between oral health and systemic health. For example, severe periodontal disease is strongly linked in observational studies to cardiovascular disease, stroke, and even low birth weight.
Yes.
So here's where it gets really tricky for clinicians. Let's imagine a patient. A 45-year-old shift worker comes into a clinic. They have severe destructive periodontitis. The statistics tell us they're at a demonstrably higher risk for suffering a heart attack. Does the inflammatory gum disease cause the heart attack?
Are the bacteria from the mouth traveling through the bloodstream and causing an atherosclerotic plaque to rupture?
Right.
This specific scenario raises an incredibly important question about epidemiological reasoning. We must rigorously differentiate between a statistical association and biological causation, despite a lot of sensational headlines over the past 2 decades claiming flossing prevents heart attacks.
You've all seen those.
Yeah. But no definitive independent causal link has been confirmed by the highest levels of evidence.
So we cannot confidently say the gum disease is causing the heart pathology.
We cannot. And the most compelling evidence against a direct causal link comes from intervention trials. The existing data suggests that if you take a cohort of patients with severe periodontitis and you treat their gums aggressively, you perform deep scaling, you successfully eliminate the oral inflammation, it does not significantly modify their long-term cardiovascular outcomes.
They don't experience fewer heart attacks just because you cured their periodontitis.
Right.
If treating the gums doesn't fix the heart, what explains the very real, undeniable statistical association we see in the population data?
To explain the association, we must recognize a concept called residual confounding. Oral diseases and general systemic diseases like cardiovascular disease share a profound overlap of common risk factors.
The most obvious being tobacco use.
Smoking independently destroys the periodontal tissues, and it independently damages the endothelial lining of the cardiovascular system. Obesity, chronic stress, and poor diets are other shared risk factors.
And epidemiologists try to use statistical models to control for these variables, right?
They try to mathematically isolate the smoking and the diet, but even when they do, the association often remains. Why? Because of the ultimate, inescapable confounder, socioeconomic status.
People living in deprivation are subjected to a complex cluster of environmental stressors that independently degrade both their oral health and their cardiovascular health simultaneously.
The gum disease doesn't cause the heart attack. The systemic deprivation causes both.
That is such a crucial distinction for clinical reasoning. It prevents us from chasing false cures. And speaking of socioeconomic status, the framework talks extensively about the social gradient. And it's vital to understand that the social gradient isn't just about extreme absolute poverty, right?
Exactly. The social gradient is a profound and pervasive concept in public health. It dictates that health outcomes worsen incrementally at every single step down the socioeconomic ladder.
It's not just a binary of the rich are healthy and the poorest are sick.
Right. If you are a middle manager with a moderate income, your statistical oral health outcomes are likely worse than the CEO of the company, but demonstrably better than the entry-level clerk. The gradient applies to everyone.
There is a finding regarding data from the United States that I found mind-blowing. It notes that the level of total tooth loss edentialism in a given U.S. state is strongly correlated to the income inequality of that state, not just the absolute level of poverty.
That is a staggering epidemiological finding. It suggests that the psychosocial stress of living in a highly stratified, unequal society, the constant awareness of your perceived lower social position, the lack of community social cohesion, actually physically manifests as biological damage.
The inequality itself is the pathogen.
It elevates allostatic load, it alters immune function, it drives coping behaviors like sugar consumption and smoking. It literally results in people losing their teeth, independent of just how many absolute dollars they have in their bank account.
Which brings us to the life course approach. The idea that this biological damage doesn't just happen overnight, it accumulates like compound interest on a debt.
There's a longitudinal study highlighted in the text where 5-year-olds with low socioeconomic status were tracked well into adulthood.
And by age 26, those individuals had worse oral health than their more affluent peers, even after the researchers controlled for their baseline oral health when they were children.
Think about the implications of that. The socioeconomic adversity they experienced during their critical developmental years left a lasting biological imprint. It altered their physiological trajectories in a way that continued to dictate their physical health outcomes 2 full decades later.
There is another study that makes this reality incredibly visceral. Researchers looked at 12-year-old children in Brazil, and they found that having brown skin color, attending an underfunded public school, and living in an area with intermediate socioeconomic indicators were actual statistically significant predictors for having calculus and bleeding gums.
You can literally ask a 12-year-old child to open their mouth, look at their gingival tissue, and see the systemic racism and class inequality of their environment reflected right back at you.
That is the tragedy, and simultaneously the immense analytical power of dental public health surveillance. The mouth does not lie, it archives the patient's environment.
So what does this all mean for how we actually intervene?
Right, because if the root causes are structural and environmental, then standing in a sterile clinic and telling an exhausted, low-income single mother to, just brush your kid's teeth better and buy less sugar is mathematically destined to fail. How does public health actually engineer a framework to fix this?
To move upstream and actually engineer a fix, we first have to abandon what we know hasn't worked. And what hasn't worked, as the evidence bluntly shows, is individualized health education.
Handing out glossy pamphlets.
Yes, repeated systematic reviews demonstrate that simply giving people information has incredibly limited effectiveness in generating long-term, sustained behavioral change.
Because behaviors aren't formed in a vacuum. People make choices based on their environment.
Precisely. Behaviors are largely determined by the social, cultural, and highly engineered commercial environments people live in. So public health developed the Common Risk Factor Approach, or CRFA.
Which means tackling risk factors common to multiple diseases.
Right. Since dental caries, obesity, type 2 diabetes, and cardiovascular disease all share common upstream risk factors, like high dietary sugar intake and tobacco use, it is vastly more efficient to target that shared risk factor at a population level.
Rather than having dentists fight sugar, cardiologists fight sugar, and endocrinologists fight sugar all in their separate silos.
Exactly.
But even the common risk factor approach runs into a major political trap for policymakers. It's a phenomenon called lifestyle drift. Let me try out an analogy to explain this.
Go for it.
Imagine you discover a massive gushing leak in the roof of a large apartment building. Rainwater is pouring into the top floor hallways, ruining everything. And instead of the building management hiring a structural engineering crew to actually fix the roof, they just buy a huge pallet of high-quality mops, hand them out to the tenants, and mandate an educational seminar on how to mop faster and more efficiently.
That is a perfect, enduring illustration of lifestyle drift. It is the pervasive tendency for national health policies to start out with grand, bold intentions of tackling upstream structural determinants, like fixing the leaky roof, like regulating food industries.
But eventually, because structural change requires massive political will and faces corporate lobbying, the policy slowly drifts back down the causal chain.
It devolves into focusing on individual behavioral choices.
Hmm.
The government ends up just handing out the mops and blaming the tenants when the floors are still wet.
And dentistry historically has been obsessed with handing out mops.
Absolutely obsessed. And the danger there isn't just that it's clinically ineffective, it's that it actively risks victim blaming. It creates a phenomenon known as social iatrogenesis. By framing oral disease purely as a moral failure of individual personal choice, we disempower the patient. We ignore the aggressive commercial environment that forced those specific unhealthy choices upon them in the first place.
To force policymakers to keep their eyes on the roof, public health utilizes the CSDH framework, the Commission on Social Determinants of Health framework. How does this structure our thinking?
The CSDH framework demands that we analyze layers of causation. At the very top, you have the socioeconomic and political context. These broad macroeconomic forces shape the structural determinants, the inequitable distribution of power, money, and resources.
Those structural factors then dictate a person's specific social position within a society, which then trickles down to intermediary determinants.
Correct. Your social position dictates your material circumstances, the physical safety of your housing, the availability of fresh food. It dictates your psychosocial factors, like your daily burden of stress. And those intermediary circumstances finally dictate your specific behavioral choices, like your diet.
The framework argues forcefully that if you want to improve health equity, you cannot just intervene at the bottom level of behavior. You have to tackle the inequitable distribution of power and money.
Which is a massive, daunting task for a public health planner. Go fix societal inequality isn't exactly an actionable to-do list for Tuesday.
Yeah, not quite. But there is a guiding principle developed by Sir Michael Marmot called proportionate universalism. What does that look like in practice?
Proportionate universalism provides a practical roadmap. It acknowledges that we need to improve the living conditions and health for everyone across the entire social gradient, a universal approach. But the intensity and the scale of the public health intervention must be increased in direct proportion to the level of social disadvantage.
To go back to your apartment building analogy, we need to put a new, solid roof over the entire building. But the tenants living in the top floor apartments, who are directly under the biggest holes, need emergency structural support, heavy-duty tarps, and new drywall immediately.
The intervention scales with the vulnerability.
That makes total sense. So what does fixing the roof actually look like in the specific context of dental public health? It looks like altering the environment so that the healthy choice isn't something a patient has to actively fight for. It simply becomes the default choice.
The most famous, the most studied, and perhaps the most heavily debated example of upstream environmental engineering in dental public health is community water fluoridation.
The history behind this is fascinating. It started almost by accident with the observation of natural fluoride occurring in the water supplies of certain towns.
The famous 21 Cities studies.
And eventually this led to the first deliberate community-wide intervention trial in Grand Rapids, Michigan in 1945. What does the definitive, modern epidemiological data tell us today about its efficacy?
The scientific consensus relies heavily on the York Review, which is a massive systematic review analyzing 88 different studies regarding water fluoridation. The data clearly shows that community water fluoridation yields a median increase of 14.6% in the proportion of children who are completely caries-free.
And crucially, it calculated a metric called the number needed to treat, or NNT. Break down the NNT for us.
The NNT is a way to measure the clinical impact of an intervention. It tells you how many people need to receive the treatment for one person to see a benefit that they wouldn't have seen otherwise. The York Review found the NNT for water fluoridation is 6.
Meaning, for every 6 children who drink optimally fluoridated water, 1 child is completely saved from developing a cavity who absolutely would have developed one without the fluoride. That is a remarkably strong NNT for a passive population-level intervention.
It is incredibly effective. It constantly, gently bathes the teeth in low levels of fluoride via the saliva throughout the entire day. This constant presence inhibits demineralization and actively enhances remineralization, replacing the dissolved calcium with fluoroapatite, which is a structurally harder crystal.
But, as you said, it is fiercely debated. I want us to unpack the ethical and political debate around water fluoridation. Let's do this completely impartially, just objectively looking at the core philosophical arguments that are constantly colliding here.
It is essential to understand the philosophical friction. On one side, the anti-fluoridation argument leans heavily on the principle of respect for autonomy. Opponents argue that adding a biologically active substance to the public water supply to prevent a non-communicable disease is a form of mass medication.
It removes the right of the individual to refuse medical treatment or to choose what goes into their own bodies.
Exactly. There are also frequent concerns raised about the risk of fluorosis, which is a cosmetic modeling of the enamel caused by systemic overexposure during tooth development.
And on the flip side, what is the ethical justification from public health bodies?
The pro-fluoridation argument leans heavily on the principles of beneficence, doing good, non-maleficence, doing no harm, and crucially, the principle of justice. Proponents argue that some minor reduction in absolute individual autonomy is entirely acceptable for the overwhelming proven biological good of the community.
And the most powerful argument is equity.
Because water fluoridation protects everyone equally regardless of their personal behavior, their income, or their ability to afford a toothbrush, it is a profound tool for social justice. It specifically helps those children who are least able to afford or access traditional dental care.
It's the classic public health friction point: individual liberty versus collective equity. Now, while fluoride makes the tooth structure vastly more resistant, it doesn't actually remove the biological cause of the disease. The necessary cause, the fuel for the fire, is dietary sugar.
Correct. Without the presence of free sugars in the oral environment, clinically significant dental caries simply does not occur. The bacteria have nothing to ferment. The World Health Organization strongly recommends that free sugars make up less than 10% of a person's total daily energy intake.
And ideally, less than 5% for maximum health benefits. But in many Western countries, a population average is hovering closer to 15%.
Right.
And history actually proved this biological requirement in a massive, unintended, real-world experiment. During World War II, when sugar was strictly rationed by governments and simply unavailable to the general public for years, dental caries levels absolutely plummeted across entire nations.
The disease almost vanished.
But trying to replicate that massive reduction in sugar today brings us face to face with the concept of commercial determinants of health.
This is arguably where public health faces its most formidable opponent. There are deep evolutionary biological reasons we crave sweet, calorie-dense foods, but the modern food industry aggressively manipulates that biology.
They continuously add hidden free sugars like high fructose corn syrup to highly processed foods that aren't even traditionally considered sweets.
Bread, pasta sauces, yogurt. Why? Because it makes the food hyperpalatable, it increases shelf life, and it drives immense, reliable corporate profit. This is the commercial determinant. The industry is actively, intentionally engineering our environment to be inherently cariogenic.
Which creates a bizarre, almost ironic paradox of consumerism. On one hand, you have the commercial food industry driving the disease process forward to maximize profits. On the other hand, one of the most successful public health interventions of all time was also driven by commercial consumerism, the mass addition of fluoride to toothpaste.
It is a fascinating duality of the free market. In the 1970s, commercial manufacturers started adding fluoride to toothpaste on a massive scale to sell more product. A major Cochrane review shows a 24% prevented fraction for fluoride toothpaste.
That means simply brushing with a fluoride paste reduces a population's decay increment by a quarter. It was driven entirely by corporate profit motives, but it resulted in a massive health benefit.
Though it's important to clarify something about the physical act of brushing. Purely mechanical plaque removal, just aggressively brushing with a dry brush or non-fluoridated paste, has very equivocal mixed evidence for actually preventing cavities.
Right. The mechanical brushing stops the gingivitis by removing the biofilm, but it's the chemical fluoride in the paste that stops the cavity.
Exactly right. The nylon bristles of the brush are essentially just a mechanical delivery vehicle for the fluoride drug. But again, relying on toothpaste brings us right back to the problem of individual behavior.
The people who need the fluoride the most are often the ones who brush the least frequently, or simply cannot afford proprietary brands of fluoridated toothpaste.
Which is exactly why public health still looks to upstream, passive vehicles like municipal water or even fluoridated milk or fluoridated salt programs in certain countries to bypass the need for daily behavioral compliance entirely.
We have the upstream tools. We know how to engineer prevention through water fluoridation and sugar regulation. But we still have millions of people who already have severe disease and are in pain right now. How do we distribute care to them? This brings us to health systems, workforce planning, and future trends.
And the defining grim rule of health systems distribution, unfortunately, was formulated by Julian Tudor Hart. It is universally known as the inverse care law.
What does the inverse care law state?
It states that the availability of good medical or social care tends to vary inversely with the need for it in the population served.
Let that sink in. The populations who need the care the absolute most have the least access to it, and the populations who need it the least have the most access.
It is the brutal, observable reality of market-driven healthcare systems. Let's look at the workforce economics. In a traditional Western model, you have a highly paid, extensively trained dentist who spent nearly a decade in specialized surgical training. Where do they choose to set up their private practice?
Usually in an affluent suburban area where patients have private insurance.
And what are they doing all day? Often, they are drilling and filling very straightforward, simple cavities or performing routine checkups on healthy mouths. Meanwhile, 100 miles away in a rural area or 5 miles away in an inner-city deprived neighborhood, there are children suffering in agonizing pain with acute abscesses, with zero access to any provider at all.
It is a massive, systemic misallocation of highly skilled clinical resources. So what is the systemic solution to fix that maldistribution?
The structural solution is completely restructuring the workforce to match the actual epidemiological need of the population. And the primary way progressive health systems do this is by expanding the use of dental care professionals, or DCPs, specifically utilizing dental therapists.
These are utilized very effectively in Australia, New Zealand, and the UK. What exactly does a dental therapist do that changes the economic equation?
A dental therapist is a highly skilled allied health professional trained specifically and intensively to do the most common routine tasks: diagnostics, simple fillings in both adult and baby teeth, and extracting baby teeth.
Because their training is highly focused on these specific tasks and significantly shorter than a traditional dentist's full medical training, they cost much less to train and employ.
If a health system deploys dental therapists directly into schools or deprived community clinics, they can handle 80% of the routine day-to-day disease burden at a fraction of the cost. This frees up the highly trained, expensive dentists to handle the complex trauma, the intricate root canals, and the severe surgical cases that actually require their advanced skill set.
It fundamentally alters the inverse care law by extending the geographic reach and economic equity of the system.
Exactly.
And what about in developing nations? In a rural clinic where electricity might be intermittent and running water might not even be available, you can't exactly set up a traditional dental chair. But there is an incredible approach called the primary oral healthcare approach, specifically utilizing RT. How do you fix a tooth without a drill?
RT stands for atraumatic restorative treatment. This is a brilliant, field-tested example of appropriate technology. It does not mean second-rate or substandard care. It means deploying clinical technology that is specifically adapted to the reality of the environment.
Right.
With ART, a trained community health worker uses simple, specialized hand instruments, no high-speed electric drills, no suction, no compressed air, to gently and quietly scoop out the soft, decayed tooth structure. Then they fill the clean cavity preparation with a specific material called glass ionomer cement.
And glass ionomer is uniquely suited for this because it chemically bonds to the tooth structure and slowly releases fluoride over time.
Exactly. It creates a robust biological seal, and the fluoride helps remineralize the surrounding weakened enamel. You don't need electricity, you don't need a heavy dental chair, and you often don't even need local anesthesia needles because using hand tools is so minimally invasive and gentle.
It is a highly effective, strictly evidence-based way to stabilize active disease and relieve pain in severely resource-limited settings. This shift toward utilizing therapists, allied professionals, and community workers brings us to a major cultural trend identified for the future: deprofessionalization. What does this mean for the future of the dental profession? Are dentists becoming obsolete?
Not obsolete, but their role is evolving. The literature calls the 21st century the century of the patient. As populations become more health literate, as they can access medical information independently on the internet, the strict old-school hierarchical power dynamics of medicine are flattening out.
It used to be a paternalistic system where the doctor was the unquestioned authority.
Right. Deprofessionalization doesn't mean dentists aren't respected professionals. It means the strict monopoly on knowledge and treatment control is shifting toward a much more collaborative, consumer-driven model. Patients now demand participation, transparency, and shared decision-making in their care.
But consumerism in dentistry has a very dark side, which I think is a fascinating future threat. And that is the absolute explosion of elective cosmetic dentistry. We are talking about extreme chemical bleaching, full mouth porcelain veneers filing down perfectly healthy teeth to create a uniform, blindingly white smile. The text actually calls this the medicalization of beauty and views it as a distinct form of iatrogenesis.
Yes. Iatrogenesis refers to harm caused directly by the medical intervention itself. When the dental industry actively promotes minor cosmetic deviations, like a slight yellowing or a minor crowding, as pathological flaws that urgently need expensive correction, they create massive supplier-induced demand.
They are utilizing irreversible surgical procedures, which always carry inherent biological risks like nerve damage or removing healthy protective enamel for a veneer, not to treat a biological disease, but to treat a socially engineered insecurity.
Exactly.
And how does that tie back to our central theme of public health, inequality, and the map of the mouth?
Because it actively, aggressively widens social stratification. Extreme cosmetic dentistry is highly expensive and only available to the affluent. By establishing a bright, artificially white, perfectly straight, uniform Hollywood smile as the normative baseline standard of professional and social acceptability, society subtly marginalizes everyone who cannot afford to purchase that standard.
The visible consumption of cosmetic dentistry creates an immediate visual marker of extreme wealth.
Consequently, it makes the natural, perhaps slightly crooked or naturally stained teeth of lower-income populations appear socially unacceptable or indicative of poor hygiene. It literally maps extreme economic inequality onto the human face in high definition.
Wow. That brings us full circle to where we started. If you are a clinician, a medical student, or a public health planner listening to this, you are caught exactly between these two worlds. The mouth is a biological, microscopic environment that you can treat with a drill or a hand scaler, but it is simultaneously a complex socioeconomic environment that you must navigate with smart policy, structural engineering, and deep empathy.
Very well said.
The next time you look at a panoramic x-ray or read a dry set of clinical statistics, ask yourself, are you just tracking the damage of a downstream flood, or are you actively looking for a way to build an upstream dam?
That is the fundamental, enduring challenge of all public health.
Let's lock this in. If you are prepping for boards or just want to solidify these frameworks, let's transition to our rapid single best answer recall prompts. These are the conceptual anchors. I will read the question, I'll pause briefly for you to formulate your answer, and then we will give the answer and point you to the specific section for review. Here we go.
Ready.
Question 1. Which diagnostic index reflects a profound epidemiological shift toward early detection and prevention of dental caries, replacing the traditional damage-oriented reliance on the DMFT index?
The answer is the ICDAS, the International Caries Detection and Assessment System. You can review the exact parameters of this shift in the epidemiology subsection under dental caries.
Question 2. True or false? Epidemiological evidence confirms that periodontal disease is an independent causal risk factor for cardiovascular disease.
False. While they are strongly associated statistically, the relationship is likely due to residual confounding from shared upstream risk factors like tobacco use and socioeconomic status. Refer to the section Links with Other Diseases.
Question 3. In the context of public health policy, what is meant by the term lifestyle drift?
Lifestyle drift is the tendency for health initiatives to initially target upstream structural determinants of health, like the leaky roof, but eventually drift back down into focusing on individual behavioral choices, like handing out mops and health education. Refer to links between oral and general health.
Question 4. According to the York Review, what is the exact number needed to treat, or NNT, for water fluoridation to yield one additional child completely free of dental caries?
The NNT is 6. You can review the details of this powerful intervention in the water fluoridation section.
Question 5. What specific approach utilizes specialized hand instruments and glass ionomer cements to treat active caries in resource-limited settings entirely without requiring electricity or running water?
Atraumatic restorative treatment, or RT, refer to management of dental caries and the use of appropriate technology subsections.
Question 6. What guiding socioeconomic principle, championed by Marmot, advocates for improving health for all portions of society universally, but intensifying the scale of action in direct proportion to the level of social disadvantage?
Proportionate universalism. Refer to the Commission on Social Determinants of Health section for a deeper dive into this framework.
Remember, that map of systemic inequality is sitting right there, waiting to be read. Until next time, here are the details of this episode.
General public health. Byline. Oral health as a window into inequality, prevention, and the integration of population-level care. O. Episode description. Oral diseases are among the most common non-communicable conditions worldwide, yet they often remain overlooked in broader health policy discussions. Dental caries, periodontal disease, and oral cancers contribute significantly to pain, disability, and reduced quality of life across all age groups. This episode explores the global burden of oral disease. This episode explores social gradients in dental health. This episode explores fluoride and population-level prevention. This episode explores sugar consumption and commercial determinants. This episode explores oral health in children and older adults. This episode explores integration of dental care within primary health systems. This episode explores workforce distribution and access challenges. This episode explores oral cancer epidemiology and tobacco exposure. This episode explores prevention versus treatment-oriented models. This episode explores dental public health illustrates how prevention can dramatically reduce disease burden. Community water fluoridation, sugar reduction policies, and early childhood programs have transformed oral health outcomes were implemented effectively. This episode explores. At the same time, inequities in access to dental services highlight broader structural issues, financing models, workforce distribution, and prioritization within health systems. This episode explores. Oral health is inseparable from overall health. It reflects both biological processes and policy decisions. This episode explores. Key takeaways. This episode explores. Oral diseases are highly prevalent globally. This episode explores. Dental caries and periodontal disease are largely preventable. This episode explores. Social and economic inequality strongly shape oral health outcomes. This episode explores. Fluoridation remains one of the most effective preventative measures. This episode explores. Sugar policy and commercial regulation influence population risk. This episode explores. Access to dental care varies widely between and within countries. This episode explores. Oral cancer prevention overlaps with tobacco and alcohol control.